My topic is complications and management of RIRS. You know, already three speakers have spoken RIRS. It's introduced actively from 1990. Now you are using in most of the stones less than 2 centimeters. There are various types of classifications. Obviously, scientific classifications only help in writing the papers, but I am giving individual case based complications with my experience after doing around 4,000 to 5,000 cases. But for the sake of introduction, modified SATAVA classification, Olivier Traxer classification, and of course, Clavien Dindo classification will be there for every surgery. So, intraoperative complications by SATAVA classification is like this. If you see these complications, a lot of us will be worried that even minimal bleeding is grade 1 complication. Inability to reach the stone is also a complication. But certain complications are very severe from grade 2A. What are they? Mucosal injury, and then converting into PCNL is also a complication. And other complications like grade 3, which always we are worried, ureteral perforation, ureteral intussusception, avulsion, like that. Severe bleeding comes in grade 2B, that is not common. Similarly, Olivier Traxer also has given simple classification. He is mainly concentrating on the ureter, not entire RIRS. Mucosa, then smooth muscle injury without only mucosal lesion 1, ureteral wall injury 2, then ureteral wall injury including mucosa and smooth muscle with advential perforation, only perforation 3, and total ureteral avulsion. Now, this modified Clavien classification is simple like anything: raised creatinine, hematuria, blood transfusion, urine infection, urinoma, which is not much useful. Like this. Now, let me show this first access sheath injury. There are various complications. I am more focusing on the surgery where we do. These are the simple injuries where if you see mucosa is gone. This happens when you don't assess the ureter before. When it happens, today actually I have to tell the management also, put the stent for a long time. Long time is how much? 3 weeks to 4 weeks. After that, it's of no use. Next is what? Follow up. With what? Ultrasound scan abdomen. How often? 2 months to 3 months. How many years? 1 year. If there is no ultrasound hydronephrosis for 1 year, you are through. 1 or 2 times you call the patient and do the ultrasound. That's all. This is another type of the ureteral accession theory, little severe. How do you know the severity? If color is red, better. If color is pale after 2 weeks, that means it's going to fibros. So you have to be more meticulous. All cases where ureteric, this is another injury where you see is again superficial injury, but sometimes you see the muscle also. To my fortune, I have not seen avulsion and complete perforation, so I am not able to show that video. And this is the another ureteric injury which a laser, if you use in the whether with flexible scope or with ureteroscope, this is a dreadful complication. So what is this complication? See, when you are using the laser fiber is more outside, and you are touching the guide wire, you are touching the stone, you are touching the ureteral wall, what not, you touched everywhere. But when you see this, nicely you have removed fragments. But when you go after 3 weeks, when patient got fever, this is classical picture like stricture urethra, where you see a fibrosed, pale, without any capillaries. That means it is very difficult to manage. I managed this patient forcibly dilating and then put stent, and continuously hydronephrosis is there and kidney function is losing. Repairing an upper ureteral stricture is difficult, sometimes equal to nephrectomy. So don't damage, push back this stone and do RIRS. Don't do in situ with especially high frequency, high energy. Don't use laser at the level of the upper ureter where wall is thin and it can easily fibrose. This is another injury where laser is used inside the ureter for 1 hour, 2 hours. Which laser? Don't ask. After 2 weeks, when you go inside, this type of the picture is seen. Entire ureter is gone. So when you use the laser for this patient, what is the option? Only Boyari flap or intestine replacement. In our case, we have done Boyari flap up to the upper end pelvis. This is at the end of the flap. Unfortunately, patient is doing well now. So when you are having ureter wall where stone is impacted, keep the laser fiber very close. Don't use high energy, high frequency. If it's possible, push back. If you are not at all comfortable, do PCNL and antigrade. You remove it is very easy. If you push back, RIRS is good if the ureter is very good. So ureteric wall assessment, laser not contacting the stone and the wall, these are the two most important as far as the ureteric injury is concerned. This is one more ureteric injury where this is a common scenario. Upper ureteric stone impacted, and then you see you have gone inside, and this is the video you see, live video where you went inside. It is a very difficult for anybody who can do ultrasound PCNL. They will do easy PCNL. But if you want to try too much from below, again and again poking, trying, this is post stented, I must tell you, post stented. See, such cases, what happens, when you go inside, everything looks easy, but at the level of the stone impaction, at the level of the stone impaction, you see here, at the level of the stone impaction, you try to pass the guide wire, it doesn't go. Terumo guide wire, zebra guide wire, other guide wires, nothing will go. I tried with flexible ureteroscope, thinking that kink I can bypass. See how slowly what you do, you will have slightly overconfidence when the guide wire is there, and then you push the flexible scope. Even I pushed. All these complications I have done. So I am not taking any other person's complications. So when I try to push, then slightly you get a little giveaway feeling. You should never get in urology in ureter giveaway feeling, something with going into a negative space. That means you are perforated. See, I have gone like this with difficulty. See, immediately do RGP. Next step, document with RGP, and immediately try to come out. Don't try to meddle with flush water like that. All your 90% of flush water will go outside the ureter, and small perinephric collection, periureteric collection will form. Immediately what you have to do, put a stent or do PCNL if you are confident, ultrasound guided. So upper ureteric stone impact, see here some amount of contrast was there luckily on that, and you go inside. One must be very good in PCNL when you are doing RIRS also. Both are complementary. You can never say that I never require PCNL, I don't do PCNL like that. It is not at all correct. These are the cases where at the end you went from above. That time also it was difficult. These are the situations where both the sides stone gets impacted. Sometimes if you don't know anything, do open ureteral lithotomy. Very good. Cut on the stone, laparoscopic ureteral lithotomy. Very good. See, now I'm in the PCNL also, guide wire is not going easily. Ultimately, I could remove it from the PCNL. During PCNL also, these are all things to be documented, because see, this is a stone which was after the kinked area is opened up, the stone is in. After that, it is easy. And one more point here, whether stone caused stricture or you caused stricture, only answer for that is have a CT scan, have a DTPS scan, have RGP before doing the procedure, have the entire video with you. Then you will be comfortable that you have not damaged. Unless you have damaged, don't show the video. You keep with yourself. Now this is over. The surgery is over, and ultimately the stent is passed, and proper placement of the stent is very important. You have to put it in some calyx, you have to put it in the bladder, because it should not fall. Some amount of rest will open the mucosa, and then it helps. That's fine. Now coming to the renal mucosal injuries. Normally, see here, you are talking somewhere and you perforate with laser fiber. Don't keep the laser fiber outside and keep the mesh on, and left and right you go inside talking to others. Then slowly after some time, if you see, that area will be bleeding, and slowly that bleeder will become a small big bleeder. So then this happens at the infundibulum. Many of these, some of the videos, some of the urologists might have seen from my side, but because a lot of people are watching now, if you see in the infundibular region, this is a Y type of stone which was going where large stone. You are in hurry. What happens in RIRS? First you do nicely, you do painting nicely for 10 minutes. After that you lose the interest. You want to break it fast 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 in the upper calyx. I also did the same 5 years back in this case. Big stone, hard stone, high laser was there with me. I was making powder. This is all like regular entry. There is no I am going here. See, this is a big stone. See, never assess the stone on CT. CT looks, our eyes is the big deceiving factor. You see only one cut CT and go. I don't know how much centimeter they have taken in between the cuts. Sometimes CT 2 centimeter can look like 2 mm. Very, very dangerous. In this case, even PCNL is difficult. See, I am doing nicely in the beginning. Vision is very good. Nicely powdering. After sometimes what happens? You try to increase the energy at the level of the infundibulum. Don't try to increase the energy. Push more inside calyx. If you push inside calyx, what maximum you can touch the mucosa as well as the papilla. In PCNL, one papilla full is gone if you dilate 30 French. But in RIRS, one papilla you cannot completely eat away. Maximum you touch. But here, while doing, slowly bleeding started. See, now I have gone into popcorn early. If you go popcorn early, you will get more frustrated. Whether it is breaking or not, you will not have vision. Where it is touching, you don't know. X-ray nicely, it is getting fragmented. But when I came out, see the blood. Why such amount of blood should come? That means you have perforated and poked somewhere the vessel, major vessel. Don't keep on seeing like this. Take it out. If you keep on seeing like that or washing continuously, blood will wash away. 5 liters also will wash away. Then what will you do? Hypotension will come. Take it out, put a stent or guide wire access, because sometimes access is important. Clots will form. The stent will aid in drainage of the urine. And then immediately see, I put a 3-way Foley's catheter, and this is the way the clots are formed and they are coming out. Then the moment these small floccules you see now, you are happy because patient clotting system is on. That means you are saved. I can't cut the with laser fiber the infundibular vessel. I might have made a hole which is 200 micrometers. Sometimes it bleeds and the pressure forms. So everybody here, I press the kidney also out of frustration, because if it continuously bleed, you cannot do angio also. It's very difficult. Peripheral region angio leak. So you try all measures, but only thing is that irrigation, stenting, blood arrangement, prepare for angioembolization. If nothing goes well, happily go home and sleep. Now, CALYCEAL rupture with scope. Sometimes flexible scope, you think that it is too flexible like a guide wire. It won't be. Flexible scope tip is very hard. See here, I have gone without talking somewhere. I have gone inside directly upper calyx perforated, and if you do RGP. So any doubt, do RGP. Any doubt anywhere in the system, do RGP. Once you see something outside, stop the procedure. Main problem is at 40 to 400 mm of Hg, water will go outside, degestant and come out. Now this is a case where difficult position is there. Baby post PCNL failed, then now inferior calyx, bifid system. I was touching here and there. I thought I will inject the RGP because multiple times I perforated. See, this is a small perforation. By the time the contrast has gone, nicely leaking. This type of leak in PCNL may be common, and we don't take it seriously because we put PCN and everything will be drained. But in RIRS, that is not there. Outside is outside, inside is inside. Inside urine goes outside, outside urine cannot go anywhere. It can get infected, it can get hematoma. So you have to be careful. Next day ultrasound, if you have doubt, do it. What if you do? If you have hematoma, large hematoma, you have to drain. Small hematoma, wait. First 1 or 2 days, don't put a knife on it. It is very difficult because inflammation will be there. Let it contain, give her higher antibiotics, and wait for some time. 90% of the hematomas resolve. But don't attempt the RIRS within 2 weeks. Again going and opening the same hole and again making hematoma is not at all advisable. Now coming to the non-functioning instrument, you think that nicely a basket I keep in the upper calyx, underestimated because of the CT film. Then basket is not coming. Sir, what we should do basket if it is not coming? All foreign baskets, I mean not Indian made, they cannot be detached. First you have to cut the basket and take out the outer sheath. Then you go by the side of it and try like this. But it is difficult. Why it is difficult? If somebody holds you one leg, the way you walk is very difficult. It is like uh, mm, entire ureter is holding. So we have to continuously go by the side of the guide wire and do it. It's very difficult. So I have done PCNL and removed it. So PCNL should be good whenever complication. And when I am removing this basket, it is getting unlooped. It's a compressed wire. So you should be careful when we are taking it out. For example, if you see here, it is broken with the laser fiber, and see compressed wire is unlooping and kilometers has come. So ultimately, X-ray also you cannot see very easily. So you should know antegradely, retrogradely. From below you pass a flexible ureteroscope, from above flexible nephroscope or ureteroscope, see everything you have removed, because small nidus of guide wires can cause foreign body formation. This is all wire which is extended. Now coming to the broken scope. Fortunately, this is done during demonstration of a flexible disposable scope. Very difficult case, post pylolithotomy. They all came with a lot of enthusiasm. I also has a lot of enthusiasm. It is like a S-shaped bend. We were so happy that this scope is going nicely. See, this is post pylolithotomy. Upper calyx. If you see plain X-ray, you think that straight it will go, but how many curvatures are there inside, we don't know. We have to pass all the curvatures. You went inside. The advantage of disposable scope is it looks very big. Happily we can do powdering, but how far? With stretched position, extended position, elbow extended, your body flexed, too many awkward positions. I realized after some time that I am I will show that I am not able to do anything. That means you what you want in your brain, it's happening so far. Suddenly now it is not happening. Just same vision is there, then it is broken. If you have broken, don't try too much hard, simply carefully take it out, because broken piece if you want to take out, you have to do PCNL. Then again doing PCNL upper pole, in this time already you have broken the scope. It is not mine, that time I was not under tension, but if it is yours, especially flexible scope directly, you will be under lot of tension. Again doing PCNL, removing the piece is difficult. There are case reports where half of the scope is inside in the ureter. Then you have to make a nick in the ureter, take out slowly, holding the ureter and taking it out. Big nuisance. So be careful. Sometimes optic bundle damage. When your day is not good, you have taken a case where high bladder neck is there, or in children, or you are negotiating with the dilpe leke, you are negotiating in the inferior calyx, I will do. Suddenly in 1 minute 100 spots will form. See, tuck 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 tuck, spots are forming in front of your eyes. Spots, if you don't observe, your assistant tell, sir, spots are forming, please stop, otherwise you will be seeing only the stone, 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 and ultimately you will break the scope and you will not break the stone. So be careful. You should not try too much beyond your limits. Any case which is difficult for RIRS is easy for PCNL. Now coming to the immediate post-operative complications. Infective complications, I am not going in detail because it's a theory. Everybody should have their own protocols. After taking steroid in my hospital, infection rate has come down. But when I was doing with chemical sterilization also, if you do more than four cases, infection more. Less than 2 cases, good. If you have two scopes, less infection. If you have a good technician who cleans, less infection. If you have infection, only antibiotic answer. If you have bleeding, you have blood, you can give more blood. If you have antibiotics are only 2 3, like I will give ceftriaxone, after that I will go to amikacin, after that I will go to piperacillin tazobactam, after that I will go to meropenem, after that I will pray the god in the house, please save. Doing TLC every day and observing. You can't remove the kidney because kidney will be very good. Even if you do PCNL, it will not be useful because it's already gone into the system. So for sepsis is a different topic, because I am particularly concentrating on surgical methods. Now I focused on this. There are a lot of papers, lot of discussions. You take care of this sterilization well. Technically you should be good. Don't show your ego for large stones. Do PCNL and happily go home. And in case where stone you can do with RIRS easily, stage it. 1 hour you keep maximum time. Thank you very much. Thank you for giving this opportunity. All these complications editing is because of my team. Obviously I should be thankful to my team, apart from entire people who are watching. Be safe at your home. Don't give shake hands and don't go close to any person. Let us fight against coronavirus. We should coronation of the coronavirus. Thank you.